Right, good evening, everyone. Hope everyone can hear me. My name is Callum. I'm one of the students from Bristol that's helped to create this series. So come along tonight to the talk on the hand, wrist and elbow, which we run by Max and Stephen, both also from Bristol. And the kind of format of this teaching series, we're going to do 15 minutes of anatomy and 15 minutes of pathology, just really short, sharp, all the key information that you need. And not only have we got this talk tonight, but we've got 5 other talks across the next 5 weeks as well. They'll all be recorded as this one is being tonight, and then we'll upload them to our website as well. And at the end of the talk, if you could fill out our feedback form, not only that would be really useful for us for developing the teaching series, but also it'd be really good because you'll get access to the slides and the summary sheet as well. So without further ado, I'll hand over to Stephen.
Hi everyone, thank you very much for coming. So today I'll be looking at the anatomy of the hand. Wrist and elbow are not getting completely ignored, but turns out 15 minutes on anatomy to do the entire upper arm is quite a lot. So I'll be focusing on the hand. Just some question in chat: how many bones in the hand and wrist? Just on one hand, post it. Doesn't matter what you say, but how many do you think we have in one hand and wrist? Any advances on 27? We've got 24. Any other answers than 27 or 24? Or you can answer for those. 25. Okay. In fact, you're winning the money with 27. So we have 8 carpal bones, 5 metacarpals, and 14 phalanges. So we've got a lovely picture here just to have a look at where you've got. So you have your 8 carpal bones, which has a nice little mnemonic we'll get onto in a minute. And then as you can see, they're moving from the thumb being the first metacarpal and then moving round second, third, fourth, and fifth. And we'll move on to the phalanges in a second. You obviously have your 2 forearm bones, but they are not in the hand at all. So your radius and your ulnar, which will meet at the wrist joint, but not make up that joint. So long to pinky, here comes the thumb, is the best way I've been told to remember those 8 carpal bones. They're really nasty to remember just because they kind of feel quite random. I will just highlight kind of what I feel is the kind of most important to remember. So your scaphoid is the bone that is very classic. There'll be questions. Makes up the anatomical snuff box, but also that scaphoid is one of the only 3 bones in the body to have a retrograde blood supply, which means it has risk of avascular necrosis, which I'm sure we'll come on to later. But that's just important to be aware of. And then the hammate's your other kind of key bone that's quite obvious because it makes a like little hammer or hook, which can result in some injuries, but also it's more visible to be able to be seen. And then we move on to those phalanges, as you can see. So you have 3 per finger, but except for the thumb, which only has 2, so that only has that 1. So the IP joint means interphalangeal joint, and normally you'd have a distal and a proximal joint. But as we say, with the thumb, it's only that proximal joint because there's only 1, and those joints are made up of articular cartilage that you have. Interestingly, 70% of your executive hand function comes from the thumb. So it's the reason why we as humans are able to do so much more than people that don't have opposable thumbs. Muscles of the hand. So there's a lot of muscles. So it will, as I say, it's very much going to be a whistle-stop tour through them. But we'll look at deep muscles first. So the interossei muscles are those intrinsic hand muscles. They originate from the intermediate surfaces of those metacarpals. So those, not the main carpal bones that make up the palm, but you're having those just on the edge. And there's 4 dorsal and 3 palmar. As I said, do not worry about the names specifically. They do have fancy names, but I wouldn't worry too much. The key thing here is knowing that there are some palmar and some dorsals, 4 and 3, respectively. And then they insert onto that proximal phalanx and allow you to abduct. So you're bringing the fingers out, and those dorsal interossei abduct, so bringing the fingers in. Interestingly, the radial artery, which we'll come on to later, but enters the hand by passing between 2 heads of the first dorsal interossei. So that's just good to know for where the placement of that is. Moving on to more superficial, as you can see on the diagram, we have quite a number of nicely named, but you've got those lumbricals, and they're thin worm-like muscles that flex those MCP joints and extend the IP joints. So that allows you to really extend the hand and acts as a fist as well. So you have tendons on the flexor digitorum profundus, and they're the only muscles in the human body that arise from tendons of another muscle. So interestingly, rather than going straight to bone. There are 3 muscles that make up the thenar eminence. So that's on the radial side. So when we talk about the hand, we talk about radial and ulnar rather than proximal and distal. So you have your oppons pollicis, and it's that deep that helps with thumb movement and opposing from other digits, allowing that extra dexterity. Your flexor pollicis brevis is actually on the ulnar side of the eminence, so it's the furthest away, and that flexes metacarpal joints. And abductor pollicis brevis is on that radial side and works in conjunction with the abductor pollicis to abduct the thumb. So that allows for thumb movement. And then we move on to the hypothenar eminence, and that's on the ulnar side. And so we have oppons digitalis minima, which is deep, and that helps with the little finger opposing the thumb. Flexor digitalis minimize, it's on the radial side of the eminence and flexes the metacarpal joint of the little finger. So again, you're moving the other side. And abductor digitalis minimi, which is on the ulnar side. And again, you're getting abduction rather than adduction of that little finger. Nerves of the hand, I'd say this is the other super relevant thing that's really good to know, broken down into ulnar, radial, and medial. And you can see on the diagram, we have those ulnar in blue, so that far side of the palmar, the dorsal side, and then when you turn over, we'll see the dorsal side. And that radial nerve is innervating those first three fingers round from the thumb, and half of that 4th finger. And you see on that palmar branch, that median nerve is taking that on when you're looking over and your hand is placed upwards. It's always quite confusing because of where you're moving your hands. So those nerves run down. So the radial nerve will run along the thumb side on the edge of the forearm, and it wraps around the end of the bone. And that gives you, as we said, that sensation to the back of the hand from the thumb to the 3rd finger. And it also supplies the back of the thumb. And that is quite important to know, as opposed to the median nerves, which travels through the carpal tunnel, which we will come on to soon about injuries to that. But you're going to have sensation to the thumb, index finger, and long finger, and then half of the ring finger. So that's where we get chopped in half that we saw on that picture before. Those thenar muscles help move the thumb and allows you to touch those tips that we often get patients to do during looking for dexterity. And that's called opposition, those motions of touching each thumb to each finger. And then as for the ulnar nerve, this travels through a separate tunnel. And this tunnel was formed by two more carpal bones, the pisiform and the hamate. So that was that hammer that we talked about before. And that there's a ligament that connects them that it passes under. And then when you pass through that canal, the ulnar nerve branches out into supplying feelings to the little finger and half the ring finger. And also you'll supply the muscles movement in the palm that pulls the thumb towards. So we talked before about those 4 key things. Vessels of the hand, they have names, but I think the main 2 that you're really looking for are your ulnar and radial arteries. So those ulnar arteries are going to move, as you can see in the fashion, moving down through on the ulnar side, funnily enough, and then the radial arteries will move to the other side towards the thumb. Max, you want to take over?
Yes, thank you very much, Stephen. Hello, everyone. I'm Max, and I'll be talking to you about some hand, wrist, and elbow pathology. So I'll just be going through some MCQs with the explanations of the MCQs, and then I'll use that to then explain a little bit about the pathologies from there. Okay. So we'll start off with MCQ. There's a 46-year-old woman who's presented to her GP with left elbow pain. It has been present for 5 weeks without any obvious trigger. On examination, there is pain on resisted wrist extension and supination whilst the elbow is extended. What is the most likely diagnosis? I'll give you about 30 seconds to a minute to have a think about that. And if you could pop any answers in the chat. Doesn't matter if you have no idea, whack in an answer, it doesn't matter, and then we'll go through it afterwards. Okay, got a couple of answers coming in. Lots of A's, lots of A's. Next slide, please, Stephen. Okay, great. So well done, everyone in the chat. You got their answer. So it is lateral epicondylitis or tennis elbow. And the reason why it is tennis elbow is because there is pain on resisted wrist extension and supination. The bit whilst it's extended, again, is useful to know, but the main thing to remember about tennis elbow is you get pain on resisted wrist extension. Okay. If we jump down to E, medial epicondylitis, that's medial epicondylitis, that's golfer's elbow. So that's where you get pain on wrist flexion, which is actually much less common than tennis elbow. So you can actually, a way to remember this or figure it out in an exam is if you can actually feel, if you just bend your wrist, so if you flex it, you can feel it on the you can feel the muscle bulk on your forearm tensing on the medial side if you flex. Whereas if you extend, then like that, pushing it away, you can feel the muscle bulk tensing on the lateral side. So you can kind of work out in the exam if you don't remember it. So that's quite a nice little trick. So the other answers, cubital tunnel syndrome. So that's more likely if you get tingling and numbness with the 4th and 5th finger, and then you get some ulnar weakness and something called ulnar claw hand as well. Olecranon bursitis, that's like just a big swelling on the back of your elbow, and most common in middle-aged men. Osteoarthritis is not likely to be so rapid as this over 5 weeks. It's much longer term and more likely in weight-bearing joints, so things like the hips and the knees. It's osteoarthritis in the elbow is a bit more likely to be down to things like trauma and that sort of thing. So yeah, next slide, please. Next slide, please, Stephen. So here's just a bit of a cheat sheet for you. If someone ever has elbow pain, you can look at this, and from the vignette of the MCQ in your finals, you should be able to get what the diagnosis is. As we've gone through, the tennis elbow, you've got a tender lateral condyle, and it's aggravated by extension, whereas the golfer's elbow is tender medial condyle, aggravated by wrist flexion. Radial tunnel syndrome is a bit more of a rare one, and can be similar to sort of tennis elbow, but it tends to be a bit further away from the lateral epicondyle. Cubital tunnel syndrome, so that's the ulnar nerve. That's your sort of your funny bone bit under there, and people get tingling in the fourth and fifth finger. And then olecranon bursitis, as we said, swelling over the posterior aspect of the elbow. Next slide. So, next question. A 30-year-old man with 5 weeks of worsening wrist pain presents to the emergency department. He has no significant past medical history apart from a visit to the emergency department 4 months ago. And at the time, he'd landed awkwardly on that same wrist, falling off a skateboard. The notes show that the x-ray of the wrist at the time was normal, and he was discharged home with safety netting advice and a repeat x-ray booked. He reports that as he had no pain at the time, he did not attend the repeat scan. What is the most appropriate initial management? Again, I'll give you about a minute to have a think about that and pop any answers you have in the chat. All right, next slide, please, Stephen. Thanks, Matt, for the question, for the answer. So the correct answer is D, and we'll go through. This is a really difficult question, and we can go through all the answers as to why D is the right answer. And it's throwing back to what Stephen said a few moments ago about the scaphoid. That's the crux of it. So the answer is inpatient MRI and orthopedics referral. So what's happened in this case is this guy has had a wrist injury. He has had a normal x-ray at the time, and then the pain's got worse. Now, what happened? The reason for this is because x-rays at the time of a scaphoid fracture, 80% of the time they can pick up the fracture, but 20% of the times, so 1 out of 5, 2 out of 10, it won't pick up the fracture straight away. Okay, so in this scenario, you've had someone who's had a mechanism of injury that is sort of consistent with a scaphoid fracture, but it didn't show up on imaging. You should still be suspicious that they could have a scaphoid fracture. Okay, and in that scenario, what you want to do is you want to get an MRI, because that is the gold, the sort of the best imaging for scaphoid fractures. Now in the UK, most places you'll probably just get another x-ray, and that will also probably show it, because these things usually take a bit of time to show up, the scaphoid fractures, so they're more likely to be, it's more sensitive about a week to 10 days later. But in this scenario, it's been so long, you would scan it again, and MRI is best, but you could also do an x-ray. And the reason for this is because of the avascular necrosis. Okay, so as Stephen was talking about earlier, 80% of the scaphoid's blood supply is derived from the dorsal carpal branch, the radial artery, in a retrograde manner, i.e., it is going back up towards the heart, not away from the heart. And what that means is that it can be quite easily compromised if you have a fracture, and then you're not getting a good blood supply to the scaphoid. It's not going to heal very well, and you can get avascular necrosis, which can be quite serious and need surgical management. All right, so that's the reason why the scaphoid fracture and avascular necrosis is the right answer. We can go through the other things. So outpatient MRI with GP follow-up. Yep, MRI would be sensible. We want to check if there's a fracture, a potential avascular necrosis or a scaphoid fracture. But because this has been so long and the risk of avascular necrosis is immediate, you need to be having specialist input right now. Second one, analgesia, referral to hand clinic for physio, safety netting. Again, hand clinic is a sensible thing. Analgesia is a sensible thing. But because this is the risk of avascular necrosis, you need specialist input, orthopedics right now. Open reduction, internal fixation. In this case, it's probably going to be needed. But the question, this is about thinking about the MCQ, thinking about the structure of the vignette. What is the most appropriate initial management? And in this case, the most appropriate initial management is diagnostic, because you need to make sure that is there a scaphoid fracture before you go cutting anything. And then finally, close reduction and splint immobilization. For lots of fuchsias, so fall on an outstretched hand and wrist fractures, that's a really common intervention and common management. That's really useful. But in this case, you're probably going to need some surgical intervention because it might be that avascular necrosis. All right, next slide. So this is going to look like a lot. It's going to look very intense, but don't worry, I'll talk you through it. Again, this is a little cheat sheet for you for anyone who's had a injury where they've fallen on an outstretched hand. So they've had a fouche. From the history and exam, that's always the first thing you start with. You can figure out what it's likely to be and then imaging after that. So if we start with the history and exam, so if you have a fouche with rotational force, i.e., then that is likely to be a Galeazzi fracture. If it's with forced pronation, it's likely to be a Monteggia. If it's a backwards fouche, i.e., they're sort of instead of out like that, then that's more likely to be Smith's. And if it's a fouche forward, just your standard, you've fallen over and you put your hands on the floor and you've heard something crunch, that's a Colles. If you have a tender anatomical snuff box, the bit just here, I can't really show up the camera, my camera's gone fuzzy, but in there, then that is likely to be a scaphoid. Also, pain on telescoping the thumb. That's pressing down the thumb like that, longitudinal compression into the scaphoid. That's going to put a force onto the scaphoid and give you pain. And then also a tender scaphoid tubercle, which is on the volar side of the scaphoid there. Okay, that's going to lead you more towards a scaphoid fracture. Looking at x-rays, so if we go back to the Galeazzi, what you're likely to see is a distal radial ulnar dislocation with a radial fracture. And then Monteggia, which is kind of the reverse Galeazzi's, that's a proximal radial ulnar dislocation. So if you imagine the two radius and ulnar at the distal end, for the Galeazzi, they detach from each other, and for a Monteggia, they detach at the proximal end near the elbow. And you also get an ulnar fracture rather than a radial fracture with Monteggia. Smith's and Colles. So this is a distal radius fracture, and the only difference is that with a Colles is the more classic one, you get dorsal displacement, i.e. that way. So you get an angulation of the bone to the dorsal end, whereas in the Smiths you get it into the volar end. And that's the only difference there. And then in terms of managing those fractures, you can, if it's stable and it's extra-articular on imaging, then you can use a non-operative approach, close reduction, immobilization with a splint or a cast. If it's displaced and intra-articular, then open reduction and internal fixation is best. And if it's open If it's an open fracture and highly comminuted, i.e. it's got loads of little bits and there's bones everywhere, then external fixation might be better. These are broad rules, not to be, obviously it's a lot more complicated than this, but for a final level, this will be more than enough. Talking about scaphoid fractures, you might see, if you suspect a scaphoid fracture based off the clinical history, but there's no x-ray changes, then you splint it or backslab it, and then you rescan in 7 to 10 days, either with an MRI, which is best, or more likely with an x-ray, because it's cheaper. If it's undisplaced scaphoid fracture, so you do see it on imaging, then a cast for 6 to 8 weeks will do. And if it's displaced, then you do surgical fixation on it. Okay, moving on.
Interestingly to add, if you're going to X-ray for a scaphoid, there is a specific scaphoid X-ray that you must request. So often this is why it's missed on a normal X-ray of the hand, because you have to ask for a specific extra to be able to actually accentuate the possibility of seeing that fracture.
Okay, so this is just a bit of a visual aid to remember the difference between Monteggia and Galeazzi. And the way to think about it is that Mugger, so MU is Monteggia and ulna, so the ulna is fractured, and Mugger GR, Galeazzi, the radius is fractured. And then remembering that in Monteggia has an A at the end, so it's the proximal bones that are dislocated, the proximal radial ulnar joint which is dislocated, and Galeazzi's got a Z at the end, so it's the distal radial ulnar joint that's affected. So that's just a little aid memoir for you to remember that by. And so we move on to the final MCQ. This is a 63-year-old woman presenting to her GP with numbness and tingling in both thumbs, index and middle fingers. And that is worse at night. It's relieved by shaking her hands, and she's worried her symptoms will stop her playing tennis. She's a typist and has a past medical history of rheumatoid arthritis. On examination, Tinel's and Phelan's test are positive bilaterally. There's wasting of the thenar eminence, and she has a BMI of 17.5. Otherwise, examination is normal. What is the patient's biggest risk factor for their condition? Is it A, playing tennis? Is it B, their occupation as a typist? Is it C, low BMI? Is it D, rheumatoid arthritis? Or is it E, not being pregnant? So I'll give you a minute or so to go over that, and then put your answers in the chat. We've got one in already. Thank you, Matt. All right, so got a couple of B's in there. I've got you with the classic one there. So typist is the risk factor. So first of all, the condition is carpal tunnel syndrome. I've tried to make that relatively obvious with all the things in the vignette. So if we look, she's a woman as a risk factor. You get numbness and tingling in both thumbs, index finger, and middle fingers. The median nerve distribution of the hand, which is what is affected in carpal tunnel syndrome, where you get sort of narrowing of that carpal tunnel where the median nerve goes through, and therefore compression of the nerve, and therefore neuropathy. Relieved by shaking hands. That's something you should really know going into MCQs and finals, because that is something they always throw in there and is almost pathognomonic for the carpal tunnel. Tinel's and Phelan's as well. They're tests for carpal tunnel, and if you see that they're positive, you know it's carpal tunnel. And wasting of thenar eminence as well is something that happens because when you get the neuropathy and the median nerve supplies the thenar eminence, basically without any innovation, that muscle bulk will just waste away. So that's why that's all relevant. So now you've got the diagnosis, if we look at the actual question, which was what's the biggest risk factor? Being a tennis player, you could think, oh, they're moving their wrist about a lot, they're doing all this sort of thing, but actually it's been shown to be quite a weak risk factor. And actually, so has being a typist, even though it's in every single sort of textbook thing about risk of carpal tunnel, actually not a strong risk factor. What occupations which are a strong risk factor are things which have vibrating tools. If you imagine using a pneumatic drill going like that all the time, that's more of a risk factor. Low BMI, so high BMI / edema and heart failure, those are sort of things that are risk factors, along with pregnancy. Basically anything that makes you swell up. And if you imagine, the way I think of it is all that fluid's got to go somewhere, and it's sort of taking up space in the carpal tunnel, so that it's going to add to any compression in there. So the key for this question about the strongest risk factor was the fact that it was bilateral carpal tunnel. If you see bilateral carpal tunnel and you think a risk factor is going to be rheumatoid arthritis, that's the most common, that's the most significant risk factor for bilateral carpal tunnel. Okay. That's just a knowledge point. In terms of the treatment of carpal tunnel, you can think about wrist splints at night is the most commonly used thing, and then occasionally people will get some steroids into the carpal tunnel, and if it's really bad, then you can get a flexor retinaculum division, which is literally where they go in during an operation and cut the flexor retinaculum, which is just a band of fibrous tissue that sits around the wrist. And if you imagine you release that fibrous band, you release a little bit of pressure, the nerve has a bit more space, and you don't get as much neuropathy. Okay. So that is the end of the talk. Thank you very much for coming, everyone. If you have any questions, feel free to either unmute yourself and ask them now, or put them in the chat, or email us as well. And if you could do the feedback for us, that'd be absolutely brilliant. It means you can get access to not only these slides, but also a summary page, which will be all the key information that me and Stephen have talked about tonight in one A4. Perfect for your finals revision, where you don't want too many bits and bobs all over the place. This is just condensed knowledge all down into one page. So I hope you all found it useful, and thank you very much for coming again. We'll stay on for a couple of minutes in case anyone asks any questions or anything like that.